The clock has struck 11. We'll go ahead and get going. Hello everyone today. I just want to say thank you for joining us today on this webinar. We'll be learning about telehealth in the post-public health emergency world. The webinar is being recorded and will be posted on our website. We'll be sending out the recording and the slides to all participants at the end of this series. I'm Mike Rowland. I'm the Telehealth and Outreach Program Specialist with the National Rural Health Resource Center, which is providing the webinar today. This webinar qualifies for ACAG credit. Caleb will be sending out an email after the final installment of this series with a link to receive those credits. Please connect your video feature by selecting the camera icon in the lower left corner of your screen. Your audio is muted by default to avoid background noise and feedback. Please remain muted unless you have a question. To unmute your line, please select the microphone icon in the lower left corner of your screen. If you dialed in, press *6 to unmute your line. You can also communicate through a chat box, which is located at the bottom ribbon in the middle of your screen. And if you haven't already, please take a moment to type your name, title, and organization in the chat box so we can know who's joining today. This helps us get a better feel for the audience on the call. Okay. Just kicking off to the center's purpose. So the National Rural Health Resource Center is a nonprofit organization dedicated to sustaining and improving healthcare in rural communities. The center is the technical assistance provider for the Delta Region Community Health Systems Development Program. The Delta Region Community Health Systems Development Program is funded by the Federal Office of Rural Health Policy in collaboration with the Delta Regional Authority. The center is committed to diversity, equity, inclusion, and anti-racism, and building a culture where difference is valued. You may learn more about it at our website. Okay, and before I introduce our speakers, one quick second, we have a pre-polling question for you. And Caleb's going to bring up the poll. The polling question is rated on a confidence scale to help us measure knowledge gains by today's webinar. Oh, everybody's already on it. Thanks so much. All right, now I'm going to introduce our speakers for today. So Stacy Gee is a member of the Forvis Healthcare Performance Advisory Services Division and focuses on hospital revenue cycle services. She's an experienced healthcare consultant with many years of experience in assisting the operational and financial performance of healthcare facilities. Valerie is a member of the Forvis Healthcare Performance Improvement Team. She has extensive experience in utilization review and case management. Her strong clinical knowledge and understanding of government and commercial payment systems brings a practical perspective to clients. She has prior experience as a provider, clinician, utilization review nurse, and nurse case manager on the facility and payer perspectives. And with that, I'll turn it over to our presenters.
Thanks, Kayla. And thank you, Mike. Well, my name is Valerie Klaus, as Caleb and Mike had introduced me. I am with Forvis. I'm a senior managing consultant, and Stacy and I are here to talk to you about telehealth, some insights and highlights post PHE. As I've shared with many clients and folks along the way, when it comes to a public health emergency, specifically a pandemic, as I was going through my nursing education, they shared with us as we get to this area in our community health nursing, hey, you'll never see this, just be familiar with it, you won't be tested on it. And then along came COVID. And so it set us up as providers, clinicians, nurses, and folks within our revenue cycle of our facilities, figuring out how are we going to deliver care when we can't be close to our patients? How are we going to deliver care when we can't lay hands on our patients? And so telehealth has really mushroomed, blossomed, however we want to phrase it, since the pandemic itself. It's given us a different modality to deliver care. And then as the public health emergency ended, questions started coming back to our team as to how is this going to affect us when it comes to as a clinician delivering care? And then how is this going to affect us as an organization financially to bill for these services post public health emergency? So with some of that in mind, that came out came this particular webinar that Stacy and I have delivered. And we have since, passed May 11th, and here we are. We still have telehealth services being delivered. It's some of our folks and more of the rural communities, as we are going to chat through, were least affected as we left the public health emergency. And then just some of the mainline service lines within our organizations that aren't CHCs or RHCs had a bit of a more direct impact of that post PHE. So we'll go ahead and I'm going to back up to this disclaimer. This is just something I want to, just chat with you about. What we are delivering today was correct as of end of business yesterday. And we all know, as we lived through this pandemic, there were items changing. It felt like even on a daily basis. So what I suggest you all to do is, take this information that we're sharing with you. If there is something that strikes a chord, or you feel like, hey, I'm not sure if this really applies to us, you reach out to us if you have the questions, but then also, be a consumer of information. We have a lot of our information in this slide deck that is resourced out. Being able to have that citation, I say go to those websites, make sure you get the most applicable information synthesized for your organization. And then, I'm going to talk a lot. Stacey and I are going to talk a lot. We're going to share a lot. But at the end of the day, none of this is to be taken as legal advice. Our agenda today, we're going to be going over, an overview of the public health emergency ending. We're going to talk about the Medicare permanent changes to telehealth. We're going to talk about the temporary Medicare changes that are through December 31st of 24, and then the temporary flexibilities that are due to expire May 11th, but then we go into additional information of things that are going to expire December 31st of 23. So that's kind of a twofold area. And then Stacy is going to get into considerations for audit. So as we've delivered these services, we all know that, newer service lines and then service lines that sometimes we feel like don't have a lot of history behind them are a bit more vulnerable for audits or to be looked at in a little deeper way. And so Stacy is going to talk through, strategies in your documentation and in your coding when it comes to telehealth services. Telehealth services have had a soaring growth. And to put this into perspective overall, telehealth has stabilized at 38 times higher than before COVID-19 hit, ranging from 13% to 17% across all specialties and remaining steady since June of 2020. Other highlights of this particular analysis that I want to share with you are about 40% of the consumers said they plan to continue using telehealth services, and that is up 11% since before the pandemic. Between 40 to 60% of consumers want a broader set of virtual care solutions. With that being said, as we talked a little bit earlier, that brings us to essentially a digital front door to our practices. And when we are looking at lowering costs, how are these virtual health visits able to drive, care, but then also are we able to lower costs? On the provider side, as of April of 21, 84% of the physicians were offering virtual services and 57% said they prefer to continue offering these services. Telehealth uptake varies significantly by specialty, with the highest penetration in psychiatry. And I believe this is something that is really driven home within that whole pandemic, telehealth care model. As a provider, when I was seeing patients in my clinic for family medicine, I'd say about 40% of my day was mental health. And as we got deeper and deeper and deeper into the pandemic, there were days where it felt like about 80 to 85% of my day was mental health. And it was due to the psychiatric care within our rural area not being able to bring in these patients for their initial consultation or their medication management. And so in family medicine, we were seeing a higher concentration of that. And that still continues to grow as far as the virtual services and telehealth for psychiatry and mental health services. December 3rd of 2020, the Department of Health and Human Services, HHS, offered grants to support a broader use of telehealth services, including the Medicare, private insurance, and through federally funded providers. Today, we're going to talk about what the PHE has done and as it has impacted the virtual care. What has Congress done to make telehealth services flexible and permanent? And within these flexibilities, how long are they going to last? And in this ever-changing landscape of telehealth, what do we need to do to get ready or be thinking about when it comes to key dates? The Omnibus or Consolidated Appropriation Act, where telehealth flexibilities were extended for 2 years in February, we got a notice that the PHE was going to end on May 11th. And now with that being said, September is rolling around for that first 151-day flexibility. And at the end of that Consolidation Appropriation Act of 2022, it gave us flexibilities through the end of December 31st, 2023, a date that I had mentioned earlier. And a lot of these then and the Appropriation Flexibilities Act has now put additional impact to that September of 2023, the 151-day extension for when it ends. So as we walk through these next couple slides, what we've developed is a timeline, because as a provider, and then as I've worked with the billing areas within different clients, these dates start to kind of swirl around, and it's like, which item or what service is affected by what date? So what we're going to try to do is help kind of unpeel this onion and get through those different dates and how they're going to affect our organization. And more importantly, how are they going to affect our patients as we're delivering care? And as you can see down here at the bottom, again, sourced material. I want to make sure that as these slides are ingested and as you guys are able to review these, that you're able to use these links and go out and get the most up-to-date information. Okay, talking through this timeline, looking at December of 2022, that's when that omnibus extended the flexibilities for 2 years. And now looking at February, that was the end notice of our PHE. We got to May 11th, which was our anticipated and actual end of our public health emergency. And now we're rolling into September. September 11th is our 151-day extension end. With that, it has a very narrow impact. As we get through the next slides, it'll help outline that for us. And then getting into January of 2024, that's our CMS calendar year 24 with the different telehealth codes that are going to begin, which really is not uncommon. As we always get to the beginning of a new calendar year, it seems like there's some different areas in coding and how it affects what we're billing. And Stacy will get into that within her slides. And then December of 24 is the flexibility end for the calendar year 2024. And then as we get into January of 2025, that is going to be when the new, again, telehealth codes begin. So as we see in this area here, where we have January of 24 and January of 25, those I say don't get too alarmed about. You know, we typically have some coding updates and changes January 1 of pretty much every year. We just need to be a bit more mindful as to how the different items in the coding and the activities of how they're coded are going to affect our organization as a whole. And again, Stacy has a lot of information in her area that she'll be able to share with you. When we're talking telehealth services, one of the most common questions we got as a consulting organization is, you know, what is considered telehealth? So many of us live out of our smartphones and we have our portals into our providers, and you know, what is considered truly telehealth? So what we'll do is we're going to talk through the definitions. So in the live audio video, we can consider that real time. It's synchronous. It is a audio video connection between a patient and a provider. Your virtual check-ins or your e-visits are patient initiated. They're a transmission of your recorded health record, and those are asynchronous. And so what I share with our clients, I think of those more of just using my chart as an example. I'm not promoting any particular platform, but within that portal platform, you're able to upload photographs, you're able to upload PDFs. So say a patient received labs outside the organization, they have a PDF, asynchronous conversation with their provider, they're able to upload those labs, make a note to the provider at 2 a.m, maybe they're a shift worker, they hit send, the provider picks it up when the provider is back in the office on the next business day. So that is your asynchronous. And then your remote physiological monitoring, your RPM. That uses electronic tools to monitor and record the patient's physiological status and transmits those to the provider where the provider is physically located. And we think of those more of like our patients who possibly have a pacemaker and they have a device at their bedside or at home that will do a every 24-hour download of what has happened within that pacemaker and upload that information to the provider. As the COVID-19 public health emergency came to an end, providers rendering those telehealth related services simply just need to take an inventory. And so as we've passed that public health emergency ending, if you've not taken an inventory of what telehealth services or flexibilities that you have taken advantage of during the public health emergency, I would say let that be one of the items you put on your checklist as we're leaving this webinar today, is to get an internal itemization of your telehealth services that you're providing. And then thinking of Medicare and telehealth prior to the public health emergency, there were so many items that Medicare, it just felt like you just could not deliver as a provider to your patient. The Center of Medicare and Medicaid, CMS, expanded the types of healthcare professionals that could furnish the distant site telehealth services to include all providers that are eligible to bill Medicare for their professional services. The expanded list of healthcare providers included, as what we previously mentioned, as well as physical therapists, occupational therapists, and speech language pathologists. That was a very welcomed change in that CMS area, being able to deliver services, especially to those Medicare clients, to keep them from backsliding on their plans of care was really, really important during the public health emergency. And we'll talk about what's still being offered post-public health emergency as we go on the slides here. And so during the public health emergency, we just shared with what providers were able to, and now post, people with Medicare can still have access to telehealth services in any geographic location in the United States, rather than those just in a rural area. So what that did is it opened up for everybody at their sites. People with Medicare were able to stay in their homes for telehealth visits, and Medicare would pay rather than having them travel to a healthcare facility. And then certain telehealth visits can still be delivered audio only, such as through the telephone, if somebody is unable to have audio video, such as smartphones and computers. And that was very, very helpful and still remains helpful for our geriatric population. Now, there are quite a few of our patients that do have smartphones and understand how to use them, but we also do have a geriatric population that still struggle with technology. So being able to have the telephonic only visits is really, really important in that telehealth services. And then the Medicare Advantage, your ACO, and your telehealth area, Medicare Advantage plans may still offer additional telehealth benefits, but just like with any other Medicare Advantage plan, your patients will have to check their benefits, or you will need to call the actual payer and have your office check their benefits. I treat all of my Medicare Advantage plans as if they're a commercial because they don't always follow the Medicare guidelines and typically don't. So be very mindful of what benefit plan your patient has and understand that no two Medicare Advantage plans seem to be the same. We'll have pockets of very similar areas, but always with every patient, don't assume just when you read the name that they have the services, call and check their benefits. After December 31st of 2024, when the flexibilities expire, ACOs may offer telehealth services and allow primary care doctors to pay without having an in-person, no matter where they live. However, again, check your client's benefits. With any of these, treat them as a commercial plan and make sure that that is an actual active benefit for them. And then for your Medicaid, your CHIP, and how that affects telehealth, Medicaid telehealth flexibilities will not be affected. States have a significant flexibility in respect to covering and paying for their Medicaid services delivered via telehealth per state requirements for approved state plans and amendments. I have a link down here, and definitely check to make sure, as well as the one down below. Check to see what your state Medicaid is offering. And again, at the end of the day, getting your client's card and truly checking their benefits for their Medicaid program is essential when it comes to their telehealth services. And then your private insurance and telehealth. Again, rolling this back up into that commercial conversation we just had with the Medicare Advantage. For information regarding your insurer's approach to telehealth, with public health emergency now being over, it would behoove you to, if they deliver telehealth services prior to the end of PHE, recheck those benefits post PHE. What is currently being offered by that payer and what is part of that benefit package, especially as we get towards the first of the year and new benefit plans are coming into effect as of January 1. Make sure that you're checking the plan for telehealth or telemedicine. You'll see them spelled out sometimes interchangeably, and other times you'll see one payer using one particular phrase and another one using another. So remembering telehealth or telemedicine as you're requesting the benefits from the patient plan. This is one of the timelines that I wanted to share with you when it came to just kind of mapping out as to how these are going to affect your organization and, at the end of the day, your patients. Some of the patients that have become very accustomed to receiving their telehealth visits and their telehealth services, you just, again, want to make sure that it is allowed by their payer and that you've done the items as far as face-to-face visits, if they're now requiring that, and you've followed their protocols to be able to deliver those telehealth services. When it comes to the rural emergency hospitals, they were added as an eligible Medicare originating site for telehealth services. So as we're looking at the different components within this slide, we have FQHCs that can now serve as a distant site. We had Medicare patients receiving telehealth services in their homes. That's going to be staying. There's going to not be any geographic restrictions for originating sites for behavioral health and mental health services. And then also behavioral health and mental telehealth services can be delivered using audio-only communication platforms at this time. Again, this information was as current as it possibly could be for this particular talk. And I know this is being recorded, so it could be listened to in weeks or months from now. Definitely keep in mind these links that we have at the bottom and check to make sure you have the most available, most current information. Again, in the telehealth permanent changes, talking about FQHCs and RHCs, serving as that distant site for behavioral and mental telehealth services, that waiver is permanent as of right now for the telehealth behavioral health services. And there'll be, possibly certain restrictions, but that permanent date for them is now 1/1/2025. Currently, there is no geographic restrictions for originating sites for your behavioral and mental telehealth services. That geographic restriction will be waived through December 31st of 2024. So as you can see, these two dates play against play right up to each other to where the flexibility was granted and then the permanency comes into place. This slide, and I'm going to have to kind of pick up the speed because Stacy has a lot of information to share with you here. Just goes into more of that behavioral health, mental telehealth care in the patient home. Being mindful of, when the inpatient visit requirement starts. This is one area where you'll want to make sure you're taking inventory of when was that last in-person visit for your patient, and do I have the staff in place to get these in-person visits completed? where we may have had more telehealth services and remote work from our nursing staff, our medical assistants in this space. We may need to bring some folks back in-house because we need to get those in-person visit requirements taken care of for our telehealth services for behavioral health. So I'm kind of running into our grocery list. We want to take an inventory of telehealth services we're providing. And now we want to add to that work list, being able to then memorialize what date was this patient's last inpatient visit. So we can make sure we get those inpatient visits scheduled in a timely manner and that we're not providing any delay in care due to the fact that their in-place visit has not taken place. In the audio-only communication area, we want to make sure, as we're working towards that January 1st of 2025 and the in-person visits, before December 31st of 2024, do we have the capabilities to offer our audio only and then also our audio video? So being mindful of the technologies that we have and being also, as we're inventorying, making sure they're HIPAA compliant and they're compliant with the services that we're providing. And then looking at the rural emergency hospital distinction as the originating site. This is an area that I'm already seeing with some of our clients, especially out west, who have taken some of their critical access hospitals and some of their smaller rural hospitals and turned them into the designation of the rural emergency hospital, the REH. Being able to, have the staffed services, the services for technology, to have that be the originating site, and then also being able to provide documentation during those visits. The temporary flexibilities that ended on May 11th of 2023, we're going to kind of gloss through those slides. I wanted them to be left in as part of the slide deck to just memorialize what has ended as of May 11th and as a reference or a resource material for you as we built upon the flexibilities and the permanent changes. So we're going to go ahead and kind of move a little bit forward here. And on this particular slide, again, just taking into note as we are going into the Ryan Haight in-person exam requirement. This again is rolling up into our providing prescribed controlled substances. There's been a lot of changes. There's been a lot of work with the DEA since the 11th of May, and they continue to work because this particular act not only affected, we typically think of pain management in this space, but it rolled into the space of our hospice services and our palliative care. So as we are working in telehealth services, understanding that, one change could have a domino effect in many different service lines. I implore you to definitely stay on top of this as far as how it is going to affect you as an organization if you're providing those services, and then also utilize the links that we have below to get up-to-date information for your organization. And then during the public health emergency, CMS waived the established patient requirement. And this rolls up into the conversation that we just had for the mental health. This rolls into just the basic remote patient monitoring, as well as just your typical chronic care management for your patients. So being mindful of those dates for when we need to have those in-person visits. That established patient visit typically would be, hey, if they were new to you, you could see them from the beginning with telehealth services. That has changed. So we need to make sure that we are compliant in that area, as well as delivering care that we're going to be able to, at the end of the day, bill for. So that rolls into staffing and also looking at your technology to make sure that you have what you need to deliver and the staff that you need to deliver the care in person. And now we're going to talk about the temporary flexibilities for expiring December 31st of 2024. FQHCs and RHCs can serve as the distant site provider for non-behavioral mental health teleservices. allowing the FQHC and RHCs to continue to act as telehealth providers. During the public health emergency, FQHCs and RHCs have been allowed to provide their services via telehealth with some restrictions, and they're going to be continued to allow to do that through December 31st of 2024. Delay and requirement in prior in-person visits, just as we had just chatted about for mental health visits, via the real-time telecommunication technology, FQHCs and RHCs during that time were allowed to provide mental health services and telehealth services without a required in-person appointment. That is going to continue through December 31st of 2024. Medicare patients that can receive telehealth services via authorized in calendar year 2023, the fee schedule in their home. During the public health emergency, CMS had reimbursement telehealth services at the same rate as an in-person visit. As we're moving forward post PHE, be mindful of how those fee schedules are starting to change. And then the temporary flexibility is expiring December 31st of 2024, that there are no geographic restrictions for the originating site for the non-behavioral mental telehealth services. And that some non-behavioral mental health teleservices can be delivered audio only. So understanding that when we have those communication platforms, again, putting this on our checklist, are they compliant? And then an in-person within 6 months of the initial behavioral health, mental health teleservices, and then annually thereafter is not required. So make plans to have your patients have their inpatient appointment prior to December 31st, 2024 to remain compliant. And then lastly, telehealth services that can be provided by physical therapy, occupational therapy, as well as speech language pathologists, such as allowing telehealth services in any geographic area. Make sure that we are compliant in that space. And in compliancy, that flows into documentation. And Stacy, again, will cover some of that as she gets into her talk with us in just a few minutes. And then here are some additional items to know. Your Medicare provider enrollment, making sure that we have those telehealth services and those providers taken, brought into account and enrolled prior to January 1st of 2024. The face-to-face requirements for your home healthcare agencies. When we're talking face-to-face, we want to make sure we're keeping into account not only the last face-to-face visit that took place, but then also looking at our internal staffing. Again, it is a global perspective of patient care required, and then also staffing needs to perform that patient care. And then hospice, that recertification process, and then the inpatient rehab facilities. A lot of these roll into that face-to-face space. And then the virtual supervision versus the direct supervision. I think with the group that we have here, it doesn't really roll into that space. There is a lot of conversation in this area when it comes to the nurse anesthetist. And so as we are rolling into this area, again, check the flexibilities that CMS has in this link below and make sure that you are compliant. And now I'm going to kick it on over to Stacy, and she has some very important information when it comes to your audit considerations and your documentation and the risks.
Thank you, Val. That's a lot of good information to take.
That was a lot of information. I am so sorry that I had to roll through it so quickly. We could talk for hours on this, couldn't we?
Exactly. I hope people took a lot of good notes, because it is a lot of good information. So thank you for that.
Thank you.
So I am going to talk specifically around some of the audits that we all know and should have known that would be coming as a result of all the telehealth expanded services. So it should be no surprise that there will be audits coming. There have been audits performed, and so we're just going to kind of talk through how you can be prepared and what you need to focus on going forward. So we know that typically the OIG has had some sort of scrutiny around the whole telehealth service as a whole. And a lot of that is based on the fact that they didn't think practitioners and providers were meeting some of the Medicare documentation requirements. So the OIG has performed some audits specific to the telehealth services that are being provided and identified some deficiencies that were occurring. And what's interesting is the OIG is putting the deficiencies that occurred are due to the lack of responsibility from the CMS onus. They're putting the onus and the responsibility back onto CMS because they're saying that CMS did not ensure that there was enough oversight to disallow payments for errors when telehealth edits couldn't be implemented. They also noted that CMS did not ensure all contractor claim edits were actually in place, and also that CMS did not ensure that practitioners were fully aware of what the telehealth benefit requirements were. So a lot of the onus back on CMS from the OIG perspective. So during the audit that the OIG has recently performed, they identified over 1,700 providers who billed telehealth services for about 500,000 beneficiaries. They identified that these providers may have billed for telehealth services that were not medically necessary and or were never even provided. And it resulted in receiving a total of over $127 million in Medicare payments. So as a result, again, putting some of the onus on these deficiencies on CMS, the OIG is recommending that CMS strengthen their monitoring and targeted oversight of telehealth services. They are recommending that CMS provide additional education to providers on appropriate billing for telehealth services. Also, that CMS improve the transparency of incident to services when clinical staff primarily delivered the telehealth service. Also, identify telehealth companies that bill Medicare and also follow up on the providers that were identified in their specific audit. So what they're saying is that CMS should conduct additional educational outreach type programs, offer additional trainings and webinars on how to appropriately bill for telehealth services. Additionally, they're saying that CMS should include information such as when it's appropriate to bill an originating site facility fee, much what Val was talking about a little bit earlier, and how to avoid Medicare, how to avoid billing Medicare fee for service and a Medicare Advantage plan for the same service. Further, they think that CMS should target specific providers with high levels of inappropriate billing for telehealth services and provide a one-on-one education to them. So although these providers that the OIG has identified in their audit represent a small proportion of approximately 742,000 providers who bill for a telehealth service. Their billing practices certainly raised some concerns in the eyes of the OIG. So as we think about what might be coming down the pike, specifically in regards to audits, the OIG has developed 7 measures based on the analysis of the Medicare data that they obtained. And so these measures focus on the different types of billings that providers may use to inappropriately bill for telehealth services. And so if we start with just number 1, they identified that some of these providers were billing both a telehealth service and a facility fee in-person service for the same date of service and for some of the visits. So you wouldn't expect a provider to bill for both the facility fee and a telehealth service for the same visit, for it literally the same encounter. So that would mean that the provider and the beneficiary were, at the same physical location if they were doing an in-person visit. So you would not expect to see both a telehealth and a facility for the same encounter. And when we look at number 2, bill telehealth services at the highest, most expensive level every single time. So in some cases, providers were billing at the highest levels, and they were concentrated in some specific medical practices. So in total, approximately 21 medical practices had multiple providers who always billed at the highest level for telehealth office visits. And in one case, a single medical practice had 30 providers who always billed at that highest level. So making sure that, we're doing accurately and reporting what we should be doing accurately. Billed telehealth services for a high number of days in a year. During the OIG audit, they identified that there were 2 family medicine providers who were billing telehealth services for literally every single day from March 1st, 2020 through February 28th of 2021. So literally every single day they were billing telehealth services. These 2 family medicine providers billed for nearly 18,600 services for more than about 1,800 beneficiaries. So they received nearly $500,000 in Medicare fee-for-service payments. Just the thought that they were billing, telehealth services for every single day, that's kind of astounding. So together, those providers billed approximately 76,000 services for slightly more than 4,300 beneficiaries. So in total, they received over $1.4 million for those telehealth services that they billed. Kind of what we talked about a little bit earlier, billing both Medicare fee-for-service and a Medicare Advantage plan for the same service. Repeatedly billing both Medicare for the same service may indicate that those providers are intentionally submitting duplicate claims, so we want to stay away from that practice. Number 5, billed a high number of hours of telehealth services per visit. Sometimes during the audit, the OIG discovered that some providers were billing more hours in telehealth than there were in a day. So really overreaching, and billing for more hours than are even physically possible. Billing telehealth services for a high number of beneficiaries. There were 2 providers that appeared to be associated with the same telehealth company that billed for more than 10,000 beneficiaries. One of the other providers in this practice billed for more than 27,400 beneficiaries for an average of 75 beneficiaries a day. If the provider rendered services every single day for a year. So that is an extreme high number of beneficiaries and encounters that they were reporting on a claim. And then billing for telehealth services and ordering medical equipment for a high proportion of beneficiaries. So one physician billed for telehealth and then ordered medical equipment and supplies for more than 400 beneficiaries, which represented almost 78% of their beneficiaries. This physician ordered 109 different types of medical equipment and supplies, totaling more than $9 million. The physician did not have any type of established relationship with any of the beneficiaries and appeared to provide these services through a telehealth company. So these are the things that the OIG discovered with their recent audit. So when we think about how can we prepare for audits, the OIG is really going to attack this in two different phases. Phase one is going to focus on making an early assessment of whether the services, such as the evaluation and management, opioid use disorder, ESRD, and psychotherapy meet the Medicare requirements. And then phase two is going to include additional audits of Medicare Part B telehealth services related to distant and originating site locations, virtual check-in services, electronic visits, remote patient monitoring, the use of telehealth technology, your annual wellness visits to determine whether those Medicare requirements are met. So, what I want to say is let's make sure that we are very concise and we are very specific with our documentation as we move through our encounters. Specifically, if they're telehealth related, we need to make sure that we are documenting, the platform that you're using during telehealth. Is it audio? Is it audio, video? All of those various types that Val talked about earlier, the different types of platforms that we use. We want to make sure that we document the platform. We want to make sure that we're documenting the patient's consent, making sure that that is documented in that encounter note, that we do have that patient's consent. We want to make sure that we are documenting the patient's location, and we want to make sure that we are documenting the provider's location. So at a minimum, we want to make sure that's the things that we're documenting. So while the expansion of telehealth has been critical to maintaining beneficiaries' access to care, it's important that new policies and technologies with potential to improve care and enhance access achieve these goals and are not compromised by fraud, abuse, or misuse. Again, so just making sure that everything that is on your claim, everything that you're reporting to that payer is supported by the documentation, concise and clear documentation. The audits that the OIG are performing are crucial to the expansion of telehealth and to maintaining these beneficiaries' access. So it's important to review the processes to ensure that you've got proper policies and technologies in place. This is going to improve care and enhance access while not compromising integrity or succumbing to fraud, abuse, or misuse. This work can help ensure that potential benefits of telehealth are realized for patients and provide the documentation for the HHS and the program as a whole. So just making sure that our documentation is there. So there are some telephone service CPT codes. So these are CPT codes that can be reported for telephone calls that have been initiated by an established patient. So they are timed codes. We need to make sure that we follow the CPT guidance for these CPT codes. If the call includes the decision to see the patient within the next 24 hours or next available appointment, they should not be billed. If the call refers to an E&M service reported by the qualified healthcare provider within the past 7 days, the telephone codes cannot be used. So making sure that we follow the time-based rules. The 99441 is the 5 to 10 minutes. The 99442 is 11 to 20 minutes, and 99443 is 21 to 28 minutes, it looks like. So making sure that we follow any time-based CPT guidance. We ask that the providers document either a start-stop time and or spent 17 minutes in discussion with patient. We really try to educate our providers to not make an open-ended statement such as spent approximately 15 minutes or spent approximately 25 minutes. Approximately is a big red flag. We need those providers to document precise either start-stop times and or the actual number of minutes that were spent, not an approximate amount of time. Okay, so when we talk specifically about telehealth services and what does that documentation look like? Again, we want to make sure that that provider documents the time that is spent in that medical decision or the medical discussion to support the procedure code. And providers have two methodologies in which they can, make an E&M selection. They can use either a time-based methodology or they can make a medical decision making methodology. It's totally up to that provider. If they're going to use a time-based methodology, they need to document a specific amount of time. Don't use canned statements or copy and paste type functions. We see a lot of copy and paste as we're doing encounter reviews, and we will see a lot of statements that have been copied and pasted that have absolutely nothing to do with the patient that provider is seeing for that specific date. So stay away from canned statements. Documentation should always be patient specific. Making sure that that provider is meeting timely physician authentication. I can tell you that CMS considers 48 hours to be timely to review and sign off and close an encounter. Understanding that different facilities have their own policies and procedures. Some will allow 7 business days, some will allow a certain number of hours, but just making sure that those physicians or those providers close out those encounters and they get them signed in a timely manner. Med necessity, only provide telehealth when it's clinically appropriate. Do not bill for telehealth if it's really only for an administrative or non-clinical discussion like lab follow-up for lab results or something like that. Only if it considers or it requires medical necessity. Document start-stop times for behavioral health. I've put behavioral health, but that really applies to any of those timed CPT codes. We tend to see a lot in behavioral health where the time is not documented. So it makes it very difficult to validate or verify an appropriate CPT code because those are some timed codes. And then again, document the patient location, the provider location, the patient consent to telehealth. Okay, so preparing for an audit. What can your organization do to prepare for these potential audits that are coming down the pike? And I know I've got 4 minutes left here, so I'm going to have to really get through this rather quickly. So assemble your communications team, have routine meetings to discuss your plans, progress, anything within the 4 walls of your facilities that are going to keep the train rolling and not get stalled. Draft communication alerts based on key dates. Identify or designate a person or a department to distribute communication, whether that's by emails or newsletters, however you feel like is going to be the most efficient way. And when I talk about communication alerts, I'm talking about as telehealth guidance changes, and as we've seen, it changes rather quickly and can change rather quickly. So just making sure that you've got a stakeholder or a designated person, a department that kind of takes ownership for staying on top of all of those regulations as they change. Incorporate telehealth training and education, stay current with the changes, keep your staff educated, have a designated person that's doing some tracking and monitoring, and then paying attention to those telehealth documentation requirements, and educate your staff to implement or incorporate requirements into their daily tasks. Accurate documentation, we've already talked about that, just making sure that the documentation is concise, accurate, and it needs to be able to support the charge that hits your claim. New policies and procedures for telehealth. Again, these changes are occurring rapidly, so stay alert and have a designated person or department and keep your policies up to date. I know from experience working in a hospital many years, Joint Commission would come in and oversee. And one of the things that I took away from one of the Joint Commission auditors is if you have a policy and procedure, you have to follow it. If you don't follow that policy and procedure, you're going to get dinged. So it's up to you to have a policy and procedure. If you don't have one, that's one thing. But if you do have a policy and procedure, you make sure that your staff are adhering to it. Otherwise, it's pretty useless. Regular monitoring and auditing, have internal monthly or quarterly audits to identify, any kind of issues, concerns, denials around your telehealth. See if you can identify some root causes, what's happening. Preserve historical claims and medical documentation as, a point of reference that you can go back to and do some comparison. Some of these others are pretty self-explanatory. Have a corporate compliance plan assessment. I would say, have your corporate compliance plan reviewed and assessed routinely, annually at a very minimum. Oh, that's the end. I got through all of that. I'm surprised I was able to get through all that. So I think we have a minute left, Mike. Sorry to rush through that last slide. I was worried I wasn't going to get all the way through it.
No, it's all right. That's kind of the saga of telehealth regulations right now, isn't it?
Yes.
Make sure you read everything. All right. Well, with that, I think we have post-polling questions that are coming in. It looks like lots of responses are dropping into that. I don't know if we have 1 minute. I don't know if anyone has any short questions.
Well, I was going to say, if anyone has any questions, please submit them and we will absolutely reach out and respond if you have any specific questions. We are happy to do that. We can get those questions from you, Mike, or Caleb. That's kind of what we've done in the past. So yes, if you have any questions, just submit them.
And it looks like our results came back for our post-polling question. A lot of confident responses in relation to updates after the PHE. Equally confident in the understanding of successful implementation in telehealth in the long run. And the same with applying the knowledge gains from today and going to the organization's financial position. All right. Well, with that, it's already noon, so we will go ahead and close up shop for today. But I just want to say thank you to everyone for the call. Thank you to Stacy and Valerie for coming, and for all those Delta sites. We are very thankful for you, and we will see you in Memphis.